Hi, all. Thanks so much for joining. We'll just give it one more minute to let folks roll on to the call. All right. Thanks everyone for joining us today. We're really thrilled to have folks tuning in for our webinar this month. Excitedly, it is Newborn Screening Awareness Month. So we want to make sure to talk about newborn screening. We know that we as an organization at NORD have been particularly active on this topic this year from the policy front, and we know that so many of you advocates and members of the community have been really heavily engaged in newborn screening this year. And we've really appreciated all that you've done to really mobilize and tell decision makers about the importance of preserving federal newborn screening activities and support of state newborn screening efforts. So we'll dive in just a second. If we could go to next slide. As always, we like to start with our mission. So, as you all know, NORD's mission is to improve the health and well-being of people living with rare diseases by driving advances in care, research, and policy. So, this is near and dear to our hearts, talking about these policy issues that we know impact members of the community. So, thrilled to have you all today. Just some housekeeping items. So we'll have a number of speakers today. My name is Tori Jem. I'm the Director of Policy and Regulatory Affairs. I'm actually stepping in for our Director of Grassroots Advocacy, Leah Barber, today, who unfortunately had a family emergency and is unable to join. So we're all thinking of her during this time, but I'll be here to support this event and happy to answer any questions you all have at the end related to the advocacy components or any other policy issues that come up. We are joined by a number of wonderful panelists from NORD as well as from outside of the organization. So Allison Harity, our senior policy analyst and newborn screening subject matter expert, will be here to provide a landscape of newborn screening policy updates. We'll be joined additionally by Andrea DeBarber and Abby Cook from the CTX Alliance to share community perspectives on newborn screening. And then we have Darby Gavin joining us to talk about the Living Rare study at the end. Other housekeeping notes, please make sure to mute your line. This meeting, as mentioned, will be recorded. Please do keep an eye out for a follow-up email tomorrow with information on the recording and any follow-up information that we want to make sure you all have accessible and easy to reach. Please feel free to use the chat for sharing resources, connecting with fellow participants. Do use the Q&A feature for directing questions to Nord or to other panelists. We will do our best at the end of the call to get to as many questions as possible while we're together. And we're always happy to follow up afterwards if you have questions we weren't able to get to or if you'd like to discuss further. We'll be ending our call promptly at 1 p.m. Eastern time to be mindful of everyone's time. We really appreciate those of you who are on the East Coast joining us for your lunch break and those of you elsewhere for joining us during this hour. So with that, I will go ahead and introduce our first panelist. Next slide, please. We have Allison Harity, as I mentioned, joining us to go over newborn screening and the policy landscape. So Allison, please take it away.
Thanks, Tori, and thanks everyone for joining us today. Happy Newborn Screening Awareness Month. If we want to go to the first slide, I'm just going to give a little bit of an overview of newborn screening generally, and then the policy landscape in the newborn screening space right now. I'm a senior policy analyst with NORD's policy team here, and kind of as Tori mentioned, I cover our access to diagnostics portfolio, which includes newborn screening and genetic testing. And this year it is a lot of newborn screening. So I'll kick it off with a kind of an overview of newborn screening. So newborn screening is an incredibly successful public health program that has a long history of successful operation in the United States. Screening identifies babies who are likely to be impacted by certain serious and life-threatening medical conditions so that they can access treatment early to prevent serious and often irreversible medical complications or even death. Newborns who are impacted by these conditions typically appear healthy at birth, and so newborn screening is critical to make sure that these newborns are identified early so that they can receive the appropriate care that they need to prevent these medical complications. Nearly all newborns born in the United States are screened through newborn screening programs. And so that's nearly 4 million newborns across the country. And over 14,000 newborns with rare conditions are identified through newborn screening each year. We could go to the next slide, please. So how does newborn screening take place? Shortly after birth, a healthcare provider pricks a newborn's heel and collects several blood spots on a filter paper card. These are sometimes called Guthrie cards after Robert Guthrie, the doctor that developed a test for PKU, which was one of the first conditions to be screened for. These dried blood spots are then sent to a public health laboratory where laboratory staff test those blood spots for conditions that are on the state or territory's newborn screening panel. These conditions vary state to state, what conditions each state screens for. But the program screens for the conditions that are on that state's panel. And then if a screen comes back positive, the health department informs that baby's healthcare provider, who then notifies the newborn's parent or guardian and connects the family to an appropriate specialist for follow-up testing. So newborn screening, it is important to note, is a screening test. It's not necessarily diagnostic. You do have to have follow-up diagnostic testing, but they're identifying newborns who are at high risk of having these conditions and are likely to have them. If we want to go to the next slide, please. So, as I mentioned, newborn screening programs operate at the state or territory level, but they do receive guidance and support from the federal government. One of the forms of guidance that states and territorial programs receive from the federal government is called the Recommended Uniform Screening Panel, or the RUSP. The RUSP is a list of conditions that the Secretary of the Department of Health and Human Services recommends states screen for as part of their newborn screening panel. Up until earlier this year, the Advisory Committee on Heritable Disorders in Newborns and Children was a federal advisory committee that played a really important role in efficiency and transparency for our national newborn screening system, and especially played an important role in the development of this recommended uniform screening panel. So this advisory committee, which I'll probably refer to as the ACHDNC, oversaw the process of recommending new conditions for addition to the RUSP. And so they would make recommendations to the Secretary of the Department of Health and Human Services about if a condition should or should not be added to the recommended uniform screening panel, that would then inform the Secretary's decision of adding a condition to the RUSP or not. And so that was, for over a decade has been the process that we've used in this country to develop this list. But the administration actually eliminated the ACHDNC on April 3rd earlier this year. And I'm going to get into a little bit about kind of what that has meant for the newborn screening community and the rare disease community. And then our friends from the CTX Alliance will share a little bit about kind of what the real world implications for that have looked like for their community afterwards as well. So if we want to go to the next slide. Oh, back one. There we go. So what has the impact of, the elimination of the ACHDNC looked like? So the Recommended Uniform Screening Panel, or the RUSP, does still exist, and the Secretary of the Department of Health and Human Services does have the authority to add conditions to the RUSP. At the time that the ACHDNC was eliminated, there were two conditions that were in kind of the final stage of the RUSP nomination process, and we're actually set to have a vote on the recommendation about these conditions about a month after the committee was eliminated. And those conditions are metachromatic leukodystrophy, or MLD, and Duchenne muscular dystrophy, or DMD. Currently, the Health Resources and Services Administration, or HRSA, has a public comment period open on the consideration of adding MLD and DMD to the RUSP, which is, a good step for these communities because They were in a very unique situation where the evidence review for these two conditions were complete. And they were kind of ready to have that vote on the recommendation of their condition to the RUSP. Um, but with the elimination of the committee, there was no one to vote on that recommendation, and that has kind of held up this process. And so, we're glad to see the administration closing the loop on these two conditions that had already gone through that process. But in the absence of a federal advisory committee, and in the absence of this process, there is not a clear process for new conditions to be nominated to be added to the RUSP, and kind of undergo this evidence review process. And this is a big problem because, these are not the last conditions, as we'll talk about in a little bit, that might be good candidates for newborn screening. There are, therapies and new tests in development every day. And we expect additional conditions, obviously, to become good candidates for newborn screening. And we need a process for these conditions to be considered for addition to the RUSP because the RUSP does play, a role in while state and territorial newborn screening programs do ultimately make decisions as to what conditions are screened for in their specific state or territory program, the RUSP does, really guide and kind of drive um, adding conditions at the state level. And there are some states that have explicitly tied their, adding new conditions to their state panel to that condition being added to the RUSP. So if we want to go to the next slide. Another thing I want to provide a little bit of an update on is the Newborn Screening Saves Lives Act. So, the Newborn Screening Saves Lives Act is a piece of legislation that was passed by a bipartisan majority of Congress in 2007 and signed into law by President Bush in 2008. This bill created the Advisory Committee on Heritable Disorders in Newborns and Children and also authorized, I should say, HRSA and CDC grants for to help with newborn screening, and also created some CDC initiatives that help support newborn screening, including the Newborn Screening Quality Assurance Program, and created the NIH Hunter Kelly Newborn Screening Research Program. So we want to go to the next slide. This initial Newborn Screening Saves Lives Act was a 5-year authorization. And so these programs need to be reauthorized every 5 years. It was reauthorized by a bipartisan majority of Congress in 2013, despite some challenges that have to do with newborn screening residual dried blood spots, and retention and secondary use of those, which is something that we don't unfortunately have time to get into today, but NORD does have a white paper that we put out earlier this year about that we can share a link to in the chat. But so it was reauthorized in 2013, but Congress failed to reauthorize this legislation again by the next deadline in 2019. And so these federal newborn screening programs, including, these the Hunter Kelly Newborn Screening Research Program, the Quality Assurance Program at CDC, and these HRSA programs have been operating without an authorization for the past 5 years. So Congress has been appropriating funds and they've been, chugging along for the most part, but have been operating without an authorization. And though Congress did not reauthorize the legislation in 2019 or another 2021 attempt, again, kind of due to these challenges around newborn screening residual dried blood spots, a provision directing the national academies to conduct a study on newborn screening was passed in an end of year package in 2022. And that National Academies study came out earlier this year. So if we want to go to the next slide. So there is another effort, especially with all of the changes that we've seen with federal newborn screening programs through the beginning of this year to, move along another newborn screening reauthorization. So the Newborn Screening Saves Lives Reauthorization Act of 2025 was introduced on July 23rd, and that's HR 4709. The bill sponsors, I have their pictures up here, but it's Representative Kelly Morrison from Minnesota, Mike Simpson from Idaho, Kim Schreier from Washington, and Nick Langworthy from New York. The current language that's been introduced is very similar to the 2021 language. And the questions around residual dried blood spots and informed consent kind of remain a concern for this legislation. But NORD is working with our newborn screening partners. We work with a coalition of advocacy organizations and professional membership organizations on kind of updating this language to hopefully make some improvements to some of these programs as they need to be brought back with the ACHD&C being eliminated earlier this year. We need something, we need a process moving forward, as I was saying earlier. And so, yes, as I saw someone put in the chat, that bill did move out of the subcommittee, the health subcommittee of the Energy and Commerce Committee on the House side earlier today, and we expect there to be a full committee markup soon. So it's very exciting that there's some momentum there, especially at a time when, not a ton of stuff is moving at the federal level. So we're very excited to see that there is a desire to move things forward on newborn screening. And so that's a little bit of an update on the newborn screening reauthorization effort. As I said, we're working with the bill sponsors to kind of hopefully update some of this language from 2021 and make improvements, as a lot of things have changed in our federal newborn screening landscape since the last time this legislation was introduced. Um, and that kind of, I think, is the overview that I have time to give today about the federal newborn screening landscape. But, I look forward, for you all to hear a little bit about kind of what the impact of some of these federal changes to the newborn screening policy landscape have meant for our community and what they might mean for the rare disease community moving forward. From a community with the CTX community that's in kind of a unique position here as well. And so I will hand it, I believe, back to Tori to do an introduction of our friends from the CTX Alliance.
Wonderful. Thanks so much, Allison. Really appreciate the brief but comprehensive overview of what's going on or what's been going on this year in newborn screening. So we are really fortunate to be joined today by Dr. Andrea DeBarber and Abby Cook. So introductions, Dr. DeBarber is a professor of chemical physiology and biochemistry at the Oregon Health and Sciences University School of Medicine. She has led a team of international researchers in the development of an assay to detect CTX for newborn screening panels. With an error rate approaching zero, it is currently in use in the New York State CTX pilot program. Very exciting. Where two babies with CTX have already been identified. For many years, she has headed up efforts to get the screen added to the RUSP, and the nomination package was to be submitted in May. But as will be discussed during this webinar, the advisory committee was dissolved. I think another important thing to note, she co-chairs the CTX Alliance Medical and Scientific Advisory Board, and in June was awarded the Hugo M. Moster Service Award by the United Leukodystrophy Foundation for her decades of service to the leukodystrophy community. Welcome, Dr. Andrea DeBarber. I think I'll quickly introduce Abby Cook as well, so you both can kind of seamlessly flow into your comments, and we're really thrilled to have you both. Abby Cook is the mother of two sons with CTX, an inherited neurological and metabolic disorder. The disease was discovered only after irreversible damage had occurred less than 3 years ago, when the children were respectively 30 and 32 years old. when Abby learned that her sons could have been treated starting at birth with a simple daily oral medication had CTX been detected in their newborn blood spots. She began to understand the impact of newborn screening. Now that there is a highly reliable screen for this treatable condition, she has made it the focus of her life to help families avoid the devastation and loss experienced by her family by advocating for adding CTX screen to the state screening panels and for the establishment of the CTX patient registry. So thank you both so much again for joining us today, and I'll turn it right over to you.
Well, thank you so much for the nice introduction, and thank you to Nord for the opportunity to speak today. You know, one of the other things that I do is I oversee a biochemical diagnostic lab at Oregon Health and Science University. And as you mentioned, lead the CTX newborn screening task force that I'll be talking about today. As well as my interactions with the CTX Alliance. So today I'll be talking about progress towards newborn screening for CTX. Next slide, please. And as you can see here, this is from one of our annual CTX meetings. This photo here of the CTX community. Next slide, please. So first, I would like to provide an introduction to CTX, or cerebrotendinous xanthomatosis. So CTX is a progressive neurological disease caused by biallelic pathogenic or lightly pathogenic variants in the CYP27A1 gene that encodes a sterol 27 hydroxylase enzyme that plays a crucial role in bile acid synthesis. So deficiency of the sterol 27 hydroxylase enzyme leads to bile acid deficiency, an accumulation of the metabolites we call cholestanol and bile alcohols that together are thought to account for the clinical signs and symptoms of CTX, which may include neonatal jaundice or cholestasis shortly after birth that can actually progress to fatal liver disease or requiring a liver transplant, chronic diarrhea from birth onwards, seizures, developmental delay, intellectual disability, juvenile cataracts. These tendon xanthomas that you can see in these photos here are bony nodules that are found on the tendons. And then psychiatric symptoms, peripheral neuropathy, cerebellar ataxia, spastic paraparesis, cognitive decline and early dementia, and death. So the bile acid, chenodeoxycholic acid, has been globally recognized as the standard of care treatment for CTX for the last 40 years or so. It's just simple 3 tablets a day and has been shown to decrease the abnormal bile acid synthesis, reduce accumulation of cholestanol and bile alcohols, and prevent disease progression in patients with CTX. Next slide, please. So although the CTX community has been supported for many years by advocacy organisations such as the United Leukodystrophy Foundation, the first patient advocacy group dedicated solely to CTX, the CTX Alliance, was incorporated in 2021. So the CTX Alliance is built on 3 core pillars, which is research and advocacy, information and education, providing information and education, and support and connection. So the mission of the CTX Alliance is to provide education, support, advocacy, and promote research for CTX patients, their families, and the medical professionals who treat and study this rare disease. The CTX Alliance is governed by a volunteer board of directors comprised of patients and professionals and guided by a medical and scientific advisory board of international experts. And this photo here is from our 2025 scientific and family meeting that was held in collaboration with the ULF. Next slide, please. So one of the first big achievements of the CTX Alliance in 2021 was supporting a successful patient-focused drug development meeting with the FDA on CTX. Next slide, please. Another important initiative of the CTX Alliance is to support what we are calling the CTX Newborn Screenings Task Force. So this task force was working to submit a nomination for CTX for consideration for addition to the RUSP. And many stakeholders participated in this group, including medical and scientific members, as you can see here, as well as patient advocates, including Jean Pickford from the CTX Alliance, Anna Grantham from Hunter's Hope, and others. Next slide, please. So why are we interested in newborn screening for CTX? So based on genetic prevalence studies and the number of identified patients, CTX is greatly underdiagnosed. It is also often diagnosed very late, with routinely a 10 to 20-year diagnostic delay after the first symptom onset. This can unfortunately result in a significant burden of irreversible neurological disease. A number of studies have shown that early identification and treatment results in improved outcomes for patients with CTX. So tools to mitigate under and late diagnosis include a greater disease awareness amongst healthcare providers, good genetic testing, sensitive and specific biochemical testing, and especially newborn screening. So we really believe that newborn screening will be the best way to identify all affected individuals and provide early treatment to prevent the progression of this disease. Next slide, please. So let me tell you a little about the timeline of efforts towards newborn screening for CTX. So in 2015, CTX was recognised as a disorder that should be screened for in newborns by the Dutch Health Council of the Netherlands. In their report, Neonatal Screening New Recommendations, the committee classified CTX as a condition where neonatal screening may prevent significant irreparable damage, but for which no suitable test methods available. The committee recommended encouragement of a pilot study of a previously developed biomarker screening method, and this molecule is shown here. This is the bioalcohol that is able to be detected in newborn dried blood spots. But at this point, the Health Council of the Netherlands said that CTX would be included when additional studies were done on this method. Next slide, please. So actually, I think there may be a slide missing on the, did we miss a slide? No, please go back a slide. There was a slide in there on describing the newborn screening testing for CTX, but I'll go over it here. So you can see a timeline towards newborn screening for CTX between 2014 to 2020. So since the time of the 2015 Dutch Health Council recognition of CTX as a candidate disorder for newborn screening, a lot of work was done on developing and validating the newborn screening. So through 2014, through 2017, 2018, and 2020, a number of studies were done in the labs of Fred Baz in the Netherlands and Mike Gelb here in the US, developing a newborn screening test for CTX. And the culmination of this was a big study in Mike Gelb's lab using 32,000 newborn dried blood spots that showed that the dried blood spot test for CTX was very effective with a false positive rate of 0. So in terms of CTX, the CTX nomination for consideration for addition to the RUSP, the first discussion of this occurred in 2016 at the United Leukodystrophy Foundation meeting. And experts came together, and by 2018, we had the first RUSP nomination ready for submission to the Advisory Committee for Heritable Disorders in Newborns and Children. And so this was submitted in 2018, and you see here myself, some physicians, CTX patients, families, and Bob Rauner, the ULF president, travelled to Rockville to attend the advisory committee meeting and provide public comment. So at this point, we received a response from the advisory committee that key evidence was missing. Next slide, please. Next slide, please. This was the response. And so the committee recognized that the nomination, is the nominated condition medically serious? Yes. Is there a widely available, clear on FDA approved confirmatory test? Yes. And are there defined treatment protocols? Yes. So the committee recognized CTX as a medically serious condition that deserves thorough consideration. It also included that there is a diagnostic test available. In terms of the committee asked the question, are prospective pilot data from population-based assessments available for this disorder? And in their opinion was no. The committee required additional information. At least one case of CTX had to be prospectively identified through a newborn screening system, specifically from a pilot study involving population-based screening of identifiable newborns, and at least one newborn had to be identified prospectively with confirmation of presence of CTX. So we went back to the drawing board again. Next slide, please. And we had to wait 4 years until CTX was included in the Screen Plus study. So the Screen Plus study is a voluntary newborn screening research study where babies are screened for additional rare disorders, and that CTX was included in this that are not currently on New York State's routine newborn screening panel. The pilot program is led by Melissa Wasserstein in conjunction with the New York State Department of Health, Dr. Joseph Orsini. So early in implementation of Screen Plus, a newborn was flagged prenatally with possible CTX, and the dried blood spot from this newborn was subsequently and independently detected as a positive screen through Screen Plus. The baby that was identified as a screen positive went on to receive a clinical and genetic diagnosis of CTX, and treatment was initiated. So there is a very low false positive rate was found by New York State, such that they felt that this test could be moved to statewide screening in New York State. So we're hoping that this will be happening later this year. But with the finding of this prospective identifiable newborn, we were able to go back and try to, hopefully, where the goal was to resubmit the nomination. Next slide, please. And so this is showing the timeline from 2021 to present. So the CTX Newborn Screening Task Force came together again and began to work on a new CTX RUSP submission. As I mentioned, a newborn was prospectively identified as part of the Screen Plus pilot study. So we had this evidence to go back to the Secretary's Advisory Committee. And during this time, the CTX Alliance was incorporated in 2021. And we've had additional support, as I said, from the United Leukodystrophy Foundation and also from Hunter's Hope, who's been supporting the development of CTX clinical care guidelines, including for newborns that would be identified through newborn screening. And so we were ready to resubmit the nomination in spring of 2025. But as Alison mentioned, at the beginning, on April 3rd, the Secretary's Advisory Committee was eliminated. Next slide, please. So where do we go from here? So in the absence of the advisory committee, there's, as Alison mentioned, there's no clear process for RUSP nomination and evidence review for new conditions. So, we will be pivoting our focus and turning to a state-by-state approach, which is not really optimal. And so, I wanted to go back in time to 2006. Shortly after the advisory committee was established in 2006, the ACMG was commissioned by the Maternal and Child Health Bureau to outline a process for standardization of outcomes and guidelines for state newborn screening programs, including a recommended uniform panel of conditions to include in state newborn screening programs that we now know as the RUSP. So in their publication from 2006, they cite at this time, there were no national newborn screening standards and limited advice available from national advisory committees regarding newborn screening policies and conditions to be included in screening mandates. At that time, the level of state resources available and the program's interpretations of available evidence concerning given conditions, the availability or expense of new screening methodologies, or public advocacy by families, healthcare professionals, or state legislators often led to divergence amongst states regarding which conditions should be mandated for newborn screening. And this divergence resulted in significant disparities in screening services available to infants. So it's very concerning because at this point, we are somewhat in the same situation again regarding the addition of new disorders for newborn screening. So that's my final slide. So with that, I will turn over to Abby Cook, who is a fellow board member of the CTX Alliance.
Thank you, Andrea. That was a lot of amazing information, and hopefully folks will check back and listen to your talk again, because you really summarized everything about CTX. I want to share with you our family's experience with CTX and explain why we feel newborn screening is so important, on a personal level. So, as mentioned, many of these rare conditions don't show in a newborn baby or even a young child. I want to show you a picture of my son, Zachary. He's a beautiful, healthy child, but little did we know there was a pernicious condition that was sending xanthomas, which are deposits not only in the tendons, but it occurred in his brain, that caused damage gradually and with symptoms that were not specific. And so it took us 30 years to get to the diagnosis that Zach had CTX. The symptom that finally got us there was the xanthoma, because very few things cause xanthomas. But the doctors, and we took our children to the most wonderful doctors. And by the way, here's my other son who has CTX. This is him at 2. He's just, both of them were so beautiful and healthy. They are amazing young men, actually. But they have had so many challenges. It finally, about 3 years ago, Zachary was at the point where he was considering taking his life. So he was one of the people with CTX who had psychiatric symptoms. The symptoms are range from the xanthomas that we mentioned, which are the deposits of metabolites and lipids that are incorrectly processed in the liver, all the way to dementia. And the only way that we found out that Ben had CTX was because Zach was diagnosed. And we think that Ben might have had dementia by the time he was 40 years old, which is crazy. So I at the time my children were born, there was no newborn screen for CTX. But if my children, and now my children are of childbearing age, if they could have it now, I would jump at the opportunity. And I would love to see families not go through what we went through. So let's keep on working on this. And I did want to say, I've been looking at the chat, and there are folks who are patient and patient advocacy groups from all over the country, from all over the world. And I want to say thank you. Everything you do brings attention to rare, and that helps all of us, regardless of what the rare condition is. I also want to say thank you to NORD, the ULF, and the CTX Alliance were our first touch points for getting information and support. So thank you so much. And I hope that, together we can help revive this system. It had some flaws, no doubt, but it's really the only thing that we had. And it also was a very careful system, going for the RUSP, very careful. And I can't imagine that all of the states would have the experts who volunteered, by the way, the experts to evaluate these new conditions to be able to add them to their screening panels. So thank you so much.
Great. Thank you so much, Dr. DeBarber, for that wonderful, comprehensive presentation. And thank you so much, Abby Cook, for sharing your personal story and your journey and your family's journey and that call to action. We're really thrilled to have you both join today. Before I jump in for very brief overview of just a refresher for, I think, many folks about how to make an impact by sharing your story, I want to call attention to us transitioning over to what you all can do today and in the near future to really take action and drive positive change to reinforce the importance of federal newborn screening efforts to support newborn screening carried out at the state level. So first, I think my colleague Jake will quickly drop in the chat a link to share your story on NORD's website. So we really can't do this work without all of your voices. One of those ways in which we get um, really appreciate being able to lift up the voice of the rare disease community is having you all share your stories, especially your newborn screening stories right now. It helps us bring those to decision makers. It helps them understand how these things impact our community in the day to day. So we really need your voice heard here. You will be hearing from us in the near future with a new action alert to message your members of Congress to urge them to support federal newborn screening programs and activities as that bill continues to progress through Congress. The Newborn Screening Saves Lives Reauthorization Act will make sure to keep you all abreast and help you mobilize to tell your members of Congress to support this critical bill. And then finally, we'll move on at the end of the call to Darby, who will share a little bit more about how you can take action through engagement in the Living Rare study. So I will just go through these slides really quickly. Next slide. So we really need your stories. We really need you to reach out to your decision makers. We'll share opportunities to do so again in the near future. But in the meantime, just refreshing everyone on story sharing and sort of the important kind of tips here. You want to make sure you're always being brief and impactful with decision makers in sharing your story. When you're reaching out to your members of Congress or other sort of decision makers at the local and state level, we encourage you to share your constituent connection, why it matters that they're hearing from you, why you're reaching out. So make sure to begin to share that you're a constituent, share the policy issue you're reaching out about. So in this case, during this month and in the coming months as that bill continues to progress, share your newborn screening experience and why federal support for state newborn screening programs is vital for the rare disease community. And make sure to frame your story in a way that focuses on impact, on the impact of their decision making to the health and well-being of the district or state as a whole. So try and branch it out, broaden it out to how your broader community can benefit from these changes. Next slide. Some more on sharing your story. It's always helpful to make sure you have a relatable story highlights that demonstrates a personal impact. So share the core messaging of your patient, your personal, your family story with details that really evoke emotion and human connection. I think there are a lot of ways in which we as an organization, NORD and other national level organizations try and share the key data to drive decision making. But along with that data and evidence about policies, we also need the anecdotes, the real human impact to help make these things tangible and real. And that's really where you all come in. Make sure to leverage your credibility. You are the expert in your story. You're the expert in your experience and your family's lived experience. Embrace that and share it. Share details about, in this case, how newborn screening has made it possible for you or your loved one or others in your community to receive essential treatments or services or life-saving benefits, or how that can offer promise to folks in the future in your community should changes be made. Next slide. Make sure you're always making the ask. Highlight the importance of preserving vital federal support for newborn screening programs, but then tie in your ask back to support for newborn screening. Again, you'll be seeing an action alert in the near future on this that will help you see exactly what the ask is that you'll make in supporting Newborn Screening Saves Lives Reauthorization Act. And then just focus also on building relationships with your lawmaker. We encourage you all to offer to be a reliable and consistent resource to lawmakers as a voice of the rare disease community and bringing that perspective to them. And we encourage you to build rapport over time, build repeated connections. Next slide. Make sure you're always thanking any decision makers or their staff you may be meeting with or talking to over the phone or communicating with via action alerts. Thank them for taking the time to hear your rare family or patient stories. And then, express hope that they will stand with the rare disease community and continue to support policies that can help protect and strengthen all of that which rare disease communities really rely on to get or stay healthy and supported. Next slide. All right, so I kept that pretty brief. We do encourage you all, if you're not already signed up, to join NORD's Rare Action Network. This is our network of grassroots community of over 21,000 advocates and volunteers focused on raising awareness and taking action to improve the health and well-being of 30 plus million Americans living with rare disease. So that's how you'll stay plugged in when we have opportunities where we're looking to help you mobilize your voice and share to your decision maker to support policies that are going to be particularly impactful to the rare disease community. Next slide. All right, so I will turn it over to Darby now, who can take us through some connections with the Living Rare study and the newborn screening issues that we've talked about today. Darby, if you want to go ahead.
Thanks so much, Tori. Hi, everyone. Thanks for joining us. If you've been on virtual NORD events before, you've probably heard me talk about this study, and I'm excited to talk about it today in the context of newborn screening and maybe what it could reveal down the line. I'm going to go really quickly. So the first thing I want to mention is that on Tuesday, September 23rd at 4 p.m. Eastern, we have a Living Rare Study specific webinar. We have webinars on this study quarterly. So if you're interested on this topic, you want to learn more, and I'm talking too fast for you to learn enough about it, and you're curious, you can join us. And maybe Jay can put that link for that event in the chat if you can find it in our folders, Jake. So with that, I'll get started. Really quickly, I work across our programmatic areas to engage rare disease community members, supporters, allies, and professionals in our mission. I work on NORD's community engagement team, so a lot of my work has a grassroots focus to it. And I spend a lot of time working on this research study that NORD launched last year. The Living Rare study is the first ever large-scale study in the US examining how experiences and challenges of people impacted by rare disease changes over time. And I'm really happy to share that to date, we've had over 2,300 people join the study, and I hope you all are inspired by some of this work that we're doing and maybe feel motivated to join along with all of the others that have to date. So what is the Living Rare study? I gave a really broad definition of it to hone in a little bit. It is a research study. It's IRB approved. It's completely online, and it's hosted on NORD's I Am Rare platform. We ask participants questions across 3 broad topic areas that you see on the screen. We ask people about the resources, time, and challenges required to manage healthcare. We ask people about the impact of rare disease on their daily life, including work, school, and finances. And we ask people about the impact of rare disease on their emotional health, their physical health, and their social health. And all the questions that we ask are related to patient and caregiver experiences. We're not collecting any clinical information. We are not asking anybody to upload any medical records. It's all about your experiences living with rare disease, navigating rare disease. The only clinical information that we ask is your diagnosis. So these are just some kind of quick facts on what you can expect if you decide to participate in the Living Rare study. So you could go to livingrarestudy.org, review the consent form. If you'd like to participate, you'd sign the consent. That's a legal document. And then you would participate fully online. It takes about 60 minutes, and you're welcome to save your progress and return at any time, though we do ask that you complete all of the surveys that you're eligible to complete within a week to ensure that kind of the long-term piece of the study is kind of falls within the time frame that we're looking to capture data. We'll be asking people to come back yearly to update their responses. The study is open to anybody in the United States that has a rare disease or is suspected of having a rare disease and is currently undiagnosed. And it's also open to caregivers. The study is kind of broken up into surveys. So there's 3 surveys. If you are somebody living with a rare disease and you're participating in the study on behalf of yourself, if you are somebody who cares for an individual with a rare disease, whether they be somebody under 18 or somebody over 18 who would not be able to participate for themselves, you are also welcome to fill out the survey. And if you are a caregiver participating, there's an additional survey, a fourth survey, to assess and understand your experience as a caregiver specifically. And I'll mention that we'll be sharing some data nuggets specific to the caregiver survey in November in alignment with National Family Caregivers Month. And I'm really excited for that. I think that some of that data is really powerful, the data that we've seen so far. I do see some questions coming in, so please put those questions in the Q&A if you don't mind. That would be great. So this study is so important because until now, there's been no way to measure the evolving needs and burdens that rare disease patients and families face. I think everybody on this call that's touched by rare disease knows what those burdens and challenges are. And at some point in your journey, you've probably felt very alone and isolated and have had trouble finding others, maybe outside of your patient advocacy organizations, that can understand what it is that you go through and just every way that rare disease impacts your life. And we undertook this effort because NORD has seen other groups, like cancer groups, diabetes groups, undertake similar efforts that have proven vital to advancing policy, creating targeted programming, and ultimately improving quality of life for their patient populations. And we're really committed to doing the same for the entire rare disease community. So in a nutshell, because I'm running out of time and Q&A is important, we'll be using this data collected through the Living Rare study to elevate research on non-clinical impacts of rare disease, inform and shape NORD's future programming, and fuel our collective advocacy efforts. So what is all of this, like, why am I talking about this? What does this have to do with newborn screening? If you're asking that question, I'm happy to tell you. So within the study, we asked participants how their diagnostic journey started, and one of the response options that you can see on the screen is abnormal newborn screening test results. So by asking this, we have the opportunity to collect really powerful information and conduct analyses that will help us compare patient experiences. So for example, we could conduct analysis to investigate difference between patient experience outcomes between states that screen for different conditions. We also heard all of our panelists talk about the absence of a process for adding conditions to the RUSP. So by participating in the Living Rare study now, we have the opportunity to collect data that may help us understand disparities in screening services down the line. So you can kind of imagine the opportunities for data analysis are really endless, and using, and comparing this question to some of the other patient experience data that we'll be collecting through the study. And again, if you want to learn more, we have that webinar on the 23rd. And on this slide, there's just a QR code. If you're interested in learning more about the study, you're interested in participating, you can head over to livingrarestudy.org. If you're a rare disease patient, caregiver, or individual suspected of having a rare diagnosis, please consider joining us in making a difference by sharing your lived experiences. As Tori said, we really cannot do this work without you. And it's a really fantastic opportunity to get engaged in advocacy and ensure that your voice is heard and your experience is counted in this data. And last but not least, if you are interested in sharing the survey, on livingrarestudy.org, we have some resources available to either post to social media, print and put in your community somewhere, share with a clinician that you see, whatever way you'd like to support this effort. We truly appreciate it. Alrighty, so I'm going to stop talking, and with that, I'm going to stop sharing as well, and I'm going to go over to the Q&A. And maybe if all of our panelists could come on camera, that would be great. I've got some questions to ask all of you. The first one is, when will the action alert come out? I'm working on some newborn screening advocacy and would love to participate. Maybe Tori, if you have any information on that.
I think Allison's going to jump in on this one.
Allison.
Yeah, sure. So we actually have a current newborn screening action alert that's kind of a broader support for federal newborn screening infrastructure alert that we can share the link to in the chat. And we do expect to kind of update that alert when we have additional insights on the progress of the Newborn Screening Saves Lives Act and the timing there. I don't have a specific timeline for that, but we will share the link for that kind of more general support. It is around Newborn Screening Awareness Month, and we can share that link in the chat for that alert.
Thanks so much, Allison. And I have another question for you, so don't go anywhere. Let's see, which one do I want to start with? We'll start with this one. Where does this, I think this question is just as a reminder to everybody, NORD scope is really focused within the United States. We do have some international partners that we work with, but just to kind of frame that for everybody. So with that, this question is, where does the USA rank in number of newborn screenings among countries doing so?
So I think it depends on kind of what you're looking at as far as rankings, but as far as, numbers of conditions ranked, the US is in, I think, a kind of similar place to other kind of European countries and things that you might expect. As Darby was saying, I'm a US policy person, and so I could tell you a lot more about the differences in state to state within the United States than I could about, where the US ranks compared to other countries.
Thank you. And then from the same person, what is the source of funding for newborn screening? So maybe you can provide some insight to that question just in the context of the United States and how our newborn screening programs are funded.
Sure. So funding for newborn screening comes from a few different places. So most states collect a fee for newborn screening, and the specific cost of that screening varies from state to state, in part because states test for different conditions and pay for their programs in different ways. Hospitals sometimes bill directly for newborn screening or include the fee in like general maternity charges. Most health insurance programs pay the fees for newborn screening and then also for families who are eligible for them. The State Children's Health Insurance Program, or CHIP, or Medicaid can pay newborn screening fees, but newborns are tested regardless of their own or their family's health insurance coverage. And then some of the funding for state programs can also come from the states themselves, but also from federal grants like those HRSA and CDC grants I mentioned earlier, and the Maternal and Child Health Services Block Grant.
Thanks so much, Allison. And we did get a question in the chat. I think this person was probably asking the context of the Living Rare study. They wrote only in USA question mark. The Living Rare study is only open to people in the United States. I will mention that there's a wonderful effort similar to the Living Rare study that's being driven by Eurordis, Rare Diseases Europe, and that's open to anybody across the globe that's living with a rare disease. So if you're interested in that project, it's called Rare Barometer. And Eurordis is EURODIS. So you could search Eurordis Rare Diseases and toggle over to get involved. And they should have some information about their Rare Barometer survey online if you'd like to participate. And that's all the time that we have. It's 12:58 and we don't want to go over. So I appreciate all of you for joining us today. We will work on getting the recording on YouTube. And please, Jake put a link to newborn screening action alert in the chat. If you have a moment to participate, we would greatly appreciate it. And I hope everybody has a lovely rest of your day. Thank you again. And thank you to our panelists.
Thank you, everyone.
Thank you.